Welcome everybody. We will be starting in about 1 minute. Okay, so I'd just like to welcome everybody to the CMV 2022 public session. And I'm just going to give an extremely brief introduction. It's fantastic so many people have been interested in joining. We have had over about 200 people who've registered today. So in today's session, what we're going to hear about is firstly from people who work for CMV Action UK, Sharon Wood and Sarah Dewar, which is the UK support group for CMV, and then a panel of experts on treatments for congenital CMV in babies and during pregnancy, testing for CMV during pregnancy and in newborns, and then finally vaccines from CMV and some exciting developments there. This will be finished off by a panel discussion when there'll be plenty of time for questions from everybody. Now, there's one particular feature of Zoom webinars which is very useful, and that is the Q&A feature. So if you check at the bottom of your screen, you'll see that there's somewhere where you can click on Q&A and then you can type in questions. Furthermore, you can see what questions other people have posed, and you can actually upvote those questions by pressing on the thumbs up button. And this will mean that the questions with the most votes rise up to the top, and they'll be the ones that we prioritize at the end to answer. Also, our panel of experts, if there's a question that seems particularly answerable by typing in, will aim to type in answers to some of the questions. So there'll be typed answers to some questions, and in some we'll raise them in the panel discussion right at the end. So without further ado, I'm going to pause for a few seconds and then move over to Sharon Wood and Sarah Dewar from CMV Action UK. I'll just stop sharing my screen. And then Sharon and Sarah, if you could share yours, that'd be brilliant. And then start as soon as you're ready.
Okay, so hopefully you can all see this, and thank you, Mike. It's absolutely great to be here this afternoon at this public session to kick off CMV 2020, and I'm sure what will be an excellent conference. Really looking forward to it. I'd like to wish all a very happy UK Mother's Day to all the mums in our audience today. So Sarah and I from CMV Action, we're going to tell you a little bit about our work and the impact of congenital CMV on the families we work with. And I'm going to kick off by telling you a little bit about our work raising awareness. And then Sarah, who is chair of trustees and also a support she does the support work herself. She's going to tell you all about the support that we offer. So I thought it was pertinent really just to kick off with a little bit of information about CMV. I'm sure most of you watching today will know all about it, but just in case you don't. Cytomegalovirus, or CMV, very common virus that can infect people of all ages, usually with few symptoms and no long-term health problems. However, if the virus is passed to an unborn baby via mum, via the placenta, and that's known as congenital CMV, it can have some very serious consequences. CMV affects 2 or 3 babies every day in the UK. That equates to about 1,000 babies every year. One of the main issues I think about it is that so few people have heard about CMV, and women that come to us always ask, well, why wasn't I told about this? Why didn't I know? And the lack of awareness concerns not only the general public, and obviously especially women, but also some of the health professionals that care for them ante and postnatally, and who don't always recognise the signs and symptoms that could lead to better treatment and care. So CMV Action, as Mike said, we are actually the only charity in the UK representing the CMV community. And we work to limit the impact of congenital CMV. Most of our governing body are parents who've been personally affected by CMV, and so we therefore have a very unique perspective on the effects of the virus. So we offer advice and support to anyone affected, and we advocate for families affected by the virus and support them as best we can. We certainly work with healthcare professionals to develop, implement research into CMV, and we're often consulted and asked to give the patient perspective in research projects, which we're always very delighted to do. And as Mike had a real success with the BBC and ITV on an item here, so we're really keen to sort of try and provide case studies where we can. So we do endeavour to raise awareness wherever we can, and I think it's worth mentioning that we actually we're a very small organisation. We only have 2 part-time employees, and although our trustees are very hands-on, there's lots of work to do on very limited resources. We don't receive any government funding, and so we're just grateful to all our wonderful supporters and families who do great things like running marathons, holding coffee mornings for us, to raise the funds on which we really do rely entirely. So really, in terms of awareness raising, these are our channels of communication. We attend professional conferences such as the Royal College of Midwives annual conference, and we reactively and proactively look for opportunities to give presentations and speak with interested parties. So for example, I speak to student midwives at UK universities and midwifery societies, etc. Always keen to provide articles for professional publications, blogs for websites, etc., etc. And whilst unfortunately COVID's had quite a significant effect on our ability to get out and about and speak directly to people, we adapted, as did everyone else, and we transferred some of these activities online. But we also took the opportunity during the pandemic to review our resources, and we've got a brand new website which is available on the old website address of www.cmvaction.org.uk. So that we think is great and is possibly much easier for people to use. And we got some brand new resources both for professionals and families. We have an e-learn module for midwives specifically, but it's also suitable for lots of other people. And that is one of the most popular on the e-learn platform hosted by the RCM. We're also planning a series of webinars for parents and professionals. We did a few before COVID, but we want to get back to doing those now, and we will very soon. We're always delighted to partner with our healthcare experts, and we're also members of things like the APPG at Westminster on baby loss, and we collaborate wherever we can with other CMV pregnancy and baby interest groups, both nationally and internationally. I'd like to mention one of the key awareness messages about CMV, which I think is very important, and that is about the transmission of CMV. Now, CMV is transmitted, as it says here, through close contact with bodily fluids, and the way women generally catch CMV is from a young child, simply because they're very good at spreading their bodily fluids around. A few simple health precautions can reduce a woman's risk of contracting CMV and passing it on to her unborn baby. So as you can see here, things like avoid putting things in the mouth that have been in a child's mouth. So don't share food, cups, dummies, utensils, etc. We say avoid the drools. So basically avoid getting saliva in your mouth when you're kissing a child or whatever. So we suggest perhaps kissing them on the head, the forehead, giving them a big hug instead of on the lips. Wash hands when things get messy. So, for example, after feeding a child, wiping the child's nose or mouth, changing a nappy, etc. And wash any items that may have been in contact with bodily fluids. So perhaps toys that have been chewed and mouthed, etc. when you pick those up. And by really adopting those few simple things, you can make a big difference. So through our support work at CMV Action, we're very aware of the emotional impact of CMV on families, and Sarah's going to talk about that a little bit more in a moment. But a couple of years ago, we decided we also wanted to look at the economic burden of CMV in the UK. So basically, we commissioned York University to estimate the costs of CMV, and they looked both at the direct costs to the NHS and the government, but also via a questionnaire to our families and parents. They looked at the wider societal and personal costs. And the results were that the estimated total cost of congenital CMV is 720 million a year, which is quite a significant amount for something that so few people have heard about. Because robust data and documentation was relatively hard to come by, we do recognise that this figure is likely to be an underestimation. This slide just breaks down findings a little bit more. So as you can see, a relatively small amount of direct costs are overshadowed by the indirect and personal costs. So basically things like families having to have time off work because of appointments and a poorly child, or a parent having to give up work or reduce hours due to complicated childcare adaptations needed, etc., etc. And long-term impairments associated with the virus certainly make up the bulk of the cost. I think anything I say and give you the facts and details of our work is never anything as powerful as the voice of the parents that we help. So I'm going to change over with Sarah at this point and just leave you with these few comments from parents, very recent comments from parents about the effect of CMV. Thank you.
Thank you, Sharon. I'm Sarah. I'm the chair of CMV Action. I've been involved with the charity for about 10 years. I started off as a support volunteer, and I then became a trustee, and now I'm chair of trustees. I'm going to start by first of all just showing you why I'm involved in CMV Action. This is my son Louis, who was born in 1998 with symptoms of CMV. He had a rash and he was very weak on one side, and he also had changes in the white matter in his brain. But he wasn't diagnosed until he was 3 years old, and that was via the blood spot test. And by that stage, he had many problems, including being profoundly deaf. I've just put up there what his education is, and also the fact he's a British Sign Language user. So I have had a lot of personal experience of CMV. What I'm doing today is I'm focusing on more of the support role of CMV Action and what people we support tell us, to give some more recent accounts. Obviously, I'm going to be looking at what the parents in the UK tell us, but I think many people who are coming from other countries internationally will probably realise, will probably have seen similar messages themselves. So starting off with the work of CMV Action Support, just a list of who we support there. We support people who are planning to become pregnant, those who've been diagnosed in pregnancy with the CMV virus. We also support professionals who are pregnant, who are working with a child or in a nursery and want some advice about our hygiene methods. We support parents with a baby or child who's been diagnosed, and a large part of this includes people who've been diagnosed quite late. And what I would say, I'll explain that a bit more later, but that's who have been diagnosed when it's too late for hospitals to consider antiviral treatment. And those are just some figures as to how many people we support. We support about 250 families each year. That's the initial support. We obviously will carry on giving them ongoing support if needed. We have about 50,000 hits a year to our website, and we also have a Facebook messaging and groups as well. And we've got about 650 members who we keep up to date with our work. So I'm just going to focus briefly on how our support actually works to explain where I got this information from for my slides. So someone who requiring support will contact either our helpline or us by email or by Facebook message, and then they will be triaged to a support volunteer who is the most suitable person with the necessary experience to help them. Support can go on for months and weeks, depending on what the concerns are. And that support volunteer will be someone who's got experience, the necessary experience. We also have a Facebook group, a private group, which has got 324 members, and they will support each other and ask each other questions. And that's CMV Action UK Family Support. I'm sure lots of you have seen changes in support offered over the years. We find that people have often searched the internet before they come to us, and they have very specific, often medical problems they want us to assist them with. And we have 2 excellent medical experts who assist us with answering the more difficult questions. And I would say, as a charity, we are well placed to see the impact of CMV on families. It's not really a scientific look at this area, it's more about what our families tell us. So in order to prepare for this talk, I looked back through some old support requests, but I also put a message on Facebook, and I got people to tell us how they felt about CMV, and these are some of the words they used. I then looked at those words and looked into more detail about why they'd said those things, and I realised that most of them related to 2 particular issues. So I'm just going to go to my next slide. So these issues were lack of awareness of the CMV virus and issues around diagnosis. So in terms of lack of awareness, people reported that they lacked awareness themselves, and also the public lacked awareness. And many of them talked about the fact they'd never been told about the CMV virus when they're pregnant, and also they'd never been told about the hygiene methods they could have used in order to reduce their risk. But they also reported lack of awareness amongst medical professionals. And you can see some of the quotes there. We had to educate them. We knew more than the doctors. They said it was very rare. And that can obviously have a huge impact if your child has been diagnosed, you've been diagnosed in pregnancy, and you don't feel you're getting the support you need from the medical professionals. The second and very related issue was diagnosis. And this really came up in 2 ways. First of all, people were concerned that they hadn't been diagnosed in pregnancy. And secondly, they were concerned that their baby or child was diagnosed very late. And often this was a baby who was diagnosed too late for antivirals, or a child where they had concerns about symptoms and had been reporting that, but no one had the awareness to actually look into the CMV virus. So I'm going to focus on those 2 areas, and I'm going to focus on them in terms of pregnancy and also in terms of with a baby or child. So I'm just going to give one example in relation to pregnancy. So just to explain for our international people who joined us internationally, the UK situation is there's no universal screening of pregnant women. A pregnant woman will contact us for support, often because they've had a scan and problems have been identified on the scan, or because they felt unwell during pregnancy and they've been tested for the CMV virus. So that's the most likely way they will contact us. Asma's going to tell us later about treatment in pregnancy, but obviously that does rely on the fact that these women have been diagnosed with the virus. So a very recent example, somebody that I contacted last week for this talk. She's pregnant. She was diagnosed after anomalies were found in her 20-week scan. She expressed uncertainties about the future for the baby, but also concerns for her family. And she was particularly upset that her 11-week-old bloods had shown as an active CMV infection, and she was told that she could have been prescribed antivirals had they known about, had those bloods been checked, but there are obviously very concerns now about the baby. And as you can see, she's really covering both of those things I mentioned. She says she's never been warned about simple preventative measures despite having young children, and also her frustration about the fact that her 11-week-old bloods weren't screened for the CMV virus. Diagnosis is also important in babies too. Just to explain the UK situation, there's no universal screening of newborns, so timing of testing is crucial. Diagnosis within the first 21 days is necessary to confirm that the CMV virus is congenitally acquired. If not, it might have been acquired after birth. And there's no treatment without diagnosis, and antivirals have to start within the first 28 days. So obviously it's very important that babies are diagnosed within those first 28 days so that antivirals can be considered and discussed. And we regularly see examples where this hasn't happened and there's a late diagnosis. Often There's been a hearing test. The baby has failed its hearing test, but unfortunately it's not within this time scale. And we are seeing more cases of late diagnosis due to COVID and lack of face-to-face appointments. Just got 3 examples of this. I will let you read the quotes, but I'll just give you the circumstances. So the one is a baby born in 2018, failed to meet her milestones. She's now unable to walk and talk, and she was diagnosed at 3 years old with CMV. Then another baby born in 2021, failed her newborn hearing test the next day, tested again in 11 days, but actually deafness wasn't diagnosed until 11 weeks, and the blood spots wasn't tested until 15.5 weeks, so no antivirals were given. And finally, a very recent person we've supported, her baby was born 6 months ago, was deaf in one ear and progressive loss in the other ear, and being investigated for seizures. And although her hearing loss was identified on day 26, the CMV wasn't diagnosed until she was 4.5 months old. So you can see there that she says this late diagnosis has a huge impact, both in terms of my continuing physical damage, but also the psychological impact on the parents. Diagnosis is also important when the child is older. The oldest child, I look back through my emails, the oldest child whose family I've supported was 17 when they were diagnosed. So a couple of years ago, we did a survey was done to look at children who were diagnosed with CMV over 4 years of age by the blood spot. And actually, this was very positive for these families because they found there was a change in medical appointments, they had increased audiology support, they had changes in education, and they had certainty. And I've given 2 examples of how those parents felt. They're 2 different parents, but one of them had blamed themselves and now they'd find out the reason for their hearing loss. And the other one recounts the numbers of scans, tests, appointments because of the lack of awareness of the virus. But actually, once they had the positive test, those investigations could then finish. Now I'd like to introduce you to a baby, Scarlett, or a little girl, Scarlett, who we used for our publicity campaign last year in Awareness Month. We did a press campaign to try and argue why there should be newborn screening of babies. So Scarlett was born in 2018. She was the first baby of her parents, and there were concerns during pregnancy because she was very small and she also had a small head. There were minor concerns at birth, including a rash and a small head, and she failed her newborn screening. And there were concerns about her development from about 4 months because she wasn't meeting her milestones. She was diagnosed with CMV before she was 1, but obviously this was too late for antivirals. And you'll see right there that Scarlett's mum talks about both of the things I've mentioned. So first of all, lack of awareness. And secondly, that she couldn't have treatment because of the late diagnosis. So she says, I really feel that Scarlett has been let down before birth and after. Early intervention is the key. And finally, Scarlett is now 3 years old and she's profoundly deaf, visually impaired, severe epilepsy, unable to sit unaided. And she attends a special nursery and also a hospice. And her mother, in that quote, talks about a lack of awareness and the emotional burden of bringing up a child such as Scarlett. Finally, I just want to say a couple of things. CMV Action supports families every day. I wanted to thank everyone who's helped me with this talk by sharing their comments. Obviously, in 10 minutes, there's been insufficient time to say what everyone's told me, but hopefully I've summarised the main issues. The main issues do appear to be concerns around awareness and also diagnosis. So the key message I would really like everyone to take away from this conference is that the virus has a huge impact on pregnant women and families. Even if the baby ends up being born healthily, it still has a big impact on women while they're pregnant. A large part of this impact comes from lack of awareness from the public and also the medical profession, and issues around diagnosis. And these are really linked to the next two talks on treatment. So my last slide is just really to make the link that unless we have awareness and diagnosis, we're still going to have difficulties with treatment. They're all linked. We need people to be aware, to make the necessary diagnosis, and therefore to link this with the treatment. And those three things all need to work together to get the best outcome for our families. And just to confirm, if anyone would like to contact us, there are details at the end. Thank you very much.
Well, thank you very much to Sarah and Sharon just now. Just to very briefly remind anyone that's just joined, if you've got any questions, please put them into the Q&A section at the bottom of this, bottom of your screen, and you can also upvote anybody else's questions that you're particularly interested in. We'll either answer them live or at the Q&A session at the end. So I'd now like to move straight on to treatments for congenital CMV. Firstly, treatment for congenital CMV in babies, and I'd like to welcome Paul Griffiths from University College London.
Thank you, Mike. So I hope you can see my slides there. This is on treatment of congenital CMV and is on behalf of Dr. Kimberlin and all the UK and USA paediatricians and also the families who took part in the study I'm just about to describe to you. As background, before recommending treatment to parents, we need evidence of both safety and efficacy from randomized controlled trials. In other words, we need to know what the drug will really do rather than just what we hope it might do. And there are two trials in the literature, both from Dr. Kimberlin, references are at the bottom there, to guide us in this area. One is with intravenous ganciclovir that was given for 6 weeks, and then oral version of this drug, valganciclovir, where children were randomized to 6 weeks versus 6 months, and 6 months was superior to 6 weeks, and so that was now adopted as the way forward. And this second study was done in collaboration with UK paediatricians. Now we know that this drug reduces the count of white blood cells in the blood and also the count of platelets, but that is reversible. It goes away when the drug is stopped, and it's also easily manageable. So there's no major safety problem here. We also know from these two trials that the drug stabilizes the hearing when it started in children aged before 1 month. So the obvious question is, would it benefit older children? Those in whom the symptoms first appear after birth, for example, or secondly, as you just heard, where there's a delay in establishing hearing loss within 1 month. It's quite difficult to get all those tests done within that particular time. So that's why we went on to do this new study, taking children who had proven sensorineural hearing loss and proven congenital CMV, those who were aged more than 1 month of age up to their 4th birthday, recruit them into the study and randomize them to receive either valganciclovir for 6 weeks or a matching placebo. And the endpoints were taking hearing tests at baseline and then at 6 months later. So the treatment is for 6 weeks and the hearing is done 6 months later. And again, this was an international study with UK and USA investigators. There were 21 sites in total, more than 1,000 children were screened, 54 were enrolled, 35 were randomized, equally distributed into the active valganciclovir group and the placebo group, and 32 completed the study. That is, they had all of their hearing and other tests. I'm just going to show you the headline results. This is looking at the viral load, the quantity of virus that's found in the urine in a series of samples that are collected from children. And you can see in the red group here who received placebo, there's very little change in the quantity of virus they have. But those given the drug, they start at the same level, but it comes down quite dramatically down to day 42 when the drug is stopped, and then it rebounds back up, perhaps to a lower level than it was at initially. And you get a similar pattern in saliva. They're starting at the same level, and there's this transient reduction in viral load while they're receiving the drug. In the blood, the levels were low in both of them and no significant difference between the two. But when we looked at hearing, these are the total ear assessments, and these are the number of ears, because of course some children had hearing problems only in one ear. And we're looking to see, did they improve? Were they normal to begin with and stayed normal, so there was no change? Were they abnormal to begin with, but there was no change because they had the same level of abnormality at the follow-up visit, or did they get any worse? And this is the group with placebo, and on the right you see the group receiving valganciclovir. Firstly, disappointingly, no children improved, and at the bottom line here, the worsening of the 7 children who worsened, 6 of them had received the active drug. We were hoping to find the results going in the opposite direction. We were hoping to alter the natural history, which we know is a progression towards a worsening of hearing loss. We're hoping to slow that down with the drug, but there's no evidence of that at all with this drug. In fact, that the trend is in the opposite direction, not significantly different, but the trend is in that direction. And that was the primary outcome of the study, so we had no significant treatment effect. A secondary outcome was the best ear hearing, and this is important because that dictates how well you'll be able to learn at school. Even if you're profoundly deaf in one ear, you may well manage quite well if you have good hearing in your other ear. The same analysis here, we're looking for improvement and worsening, and again there were no improvements and worsening in 3 children, all of whom had received valganciclovir. So we'll be publishing a full report, so physicians and paediatricians can read the details, but generally our initial observations are, first of all, the good news, there's no novel toxicity from valganciclovir in this age group. It is safe enough to be used in children. It reduced the viral load in the urine and the saliva, but disappointingly, there was no benefit on hearing. How can we explain that? Well, one possibility is that the drug is reaching the kidneys and the salivary glands to inhibit the virus at those sites, but isn't reaching the inner ear. So one question is, does the drug cross the blood inner ear barrier in these older children? It clearly does in the younger children recruited within the first month of life, but it's possible that this barrier is becoming established in older children and so preventing the drug getting across into the inner ear. That's one possibility we'd like to look at. Second set, is the disease process the same in young children who are born with symptoms compared to older children? Might a subset benefit from this drug, whereas others, that it offers no benefit? And what is the balance of damage to the ear from CMV virus replicating directly in cells in the inner ear, as opposed to the virus sitting in those cells, but an inflammatory response to the presence of CMV attacking and destroying those cells within the ear? This used to be quite a detailed small print part of the discussion among medical professionals, but now with COVID, I think you can see we're really asking, is this the presence of the virus, SARS coronavirus 2, or is this the inflammatory response to the presence of the virus that's giving most disease? And we need to know this for CMV, because it might be that anti-inflammatory treatments would be something to consider. We also need to accept that we don't know the ideal timing of hearing assessment. Should it be done right at the end of treatment, which was 6 weeks in this case? Should it be done a few months later, which was 6 months in this trial, to match up with what was done in the other 2 randomized controlled trials? Or should it be even longer, say a year or more, so that we get a better handle on any alterations to the long-term effect on hearing? And since we don't know about this, perhaps all time points should be assessed in future trials. And the last point is the duration of therapy. Certainly 6 weeks seems insufficient for this age group. Should we now study 6 months treatment in these older children, now that we have evidence from the 6 months trial in younger children that the drug is safe? Clearly, if we did such a study, randomization to placebo would be ethical because there's no established standard of care. We wouldn't want to deny treatment, an established treatment to children who present with CMV, but we have no evidence that this drug could be indicated for those children. So we think placebo would be the control. But larger numbers will be needed to assess all of these variables. Instead of studying 50 old children, we should be looking to recruit several hundred children. So from this session, if people are answering questions, I'd quite like to get some feedback from the parents and ask, would you encourage us to do such a study? And do you think several hundred children could be recruited in a few years in order to study the effect of this drug? Thank you.
Excellent. Thank you very much, Paul. So I'd now like to move straight on to treatment of CMV in pregnancy. And for this, I'd like to turn to Asma Khalil from St George's Hospital in London, UK.
Oh, okay, thank you so much. Can you see my slides now?
Yep, we can.
Okay, fantastic. Well, thank you so much. I'm going to talk to you about the treatment of CMV during pregnancy. But before I talk to you about the treatment, I'm just going to talk to you briefly about the diagnosis. How do we actually diagnose congenital or fetal infection during pregnancy? And we do that by doing a procedure called amniocentesis, which is essentially taking a small amount of the fluid around the baby. Well, the amniotic fluid is mainly made of the fetal or the baby's urine, and we know that the virus passes in the urine, and therefore we can actually detect the virus in the amniotic fluid. It's important that when we time or we plan the amniocentesis, that we wait until about 8 weeks after the mom's infection, so that allows time for the virus, if it were to cross the placenta and infect the baby, and then is present or secreted in the fetal urine. And it's also usually scheduled after 20 weeks, at what point most of the amniotic fluid comes from the baby's urine. Can we actually use the chance of the virus crossing the placenta and passing from the mother to the baby? And the answer is yes, we can do by giving the valacyclovir. It's a drug. When the mother takes it, it converts into acyclovir, which is a drug that most of us are familiar with because we've been using it for years for the cold sore, and therefore we know that's safe in pregnancy. The difference in that in this trial, we use a much larger dose of valacyclovir of 8 grams per day. That's about 16 tablets per day. And in this important trial, this is a randomized controlled trial, so that's the best quality evidence that we can get. And in this trial, the women who had CMV infection, primary infection, means getting it for the first time when they had it early in pregnancy, they were randomized, so they had 2 groups. One group that received the valacyclovir, the medicine, and the other group gets placebo, which means a fake medicine. And we look at the chance of transmission. In the group that had the medicine or that had the valacyclovir, it was about 11% where there was transmission or the virus crossed the placenta, compared to about 30% in the group that had placebo. So that means that valacyclovir reduces the chance of the virus crossing the placenta by about 71%. It's important to highlight that this trial, this is where women who had primary infection for the first time early in pregnancy. So that's either in the first trimester, that's the first third of the pregnancy, or in the periconception period, that's about few weeks around the time of conception, around the time of getting pregnant. And therefore, we don't know whether if we give the treatment later in pregnancy, that would have the same effect or not. Okay, well, let's, if in a case where the virus has crossed the placenta, we have confirmed that the baby, or there is fetal infection, or there's congenital CMV infection, how do we assess the severity? How can we assess whether this baby will be in the group that will be harmed by the virus, will have severe symptoms at birth, or will be in the 90% which actually don't have problems or are asymptomatic at birth? And we do that by looking at 3 things. Number 1, the timing of the mother's infection. Number 2, whether there are abnormalities in the baby, and that's usually using ultrasound scan or MRI. And it's not just the presence of abnormalities, it's also the type of abnormalities, because not all abnormalities means that the baby will have significant disability. And the third thing is doing some laboratory tests. And timing of infection, if you see these figures, it's clear that the chance the virus crosses the placenta from the mother to the baby is much higher the later the infection occurs. So if it's in the second half of the pregnancy, second trimester or third trimester, the chance of transmission from the mother to the baby is much higher. However, you see the opposite pattern when you look at chance of having severe symptoms or potential harm to the baby. The chance of having severe symptoms is much higher if the infection of the mom gets infection early in pregnancy, in the first trimester, the first third of the pregnancy, or in the periconceptional period. And why is that? Well, if you look at fetal development and you look at the early stage, the first trimester is a critical period because this is where the organs are developing. And for example, if you look at these various systems, so for example, if you look at the ears or the central nervous system, so that includes the brain, and you see the light shaded bars or the areas, this is a time of greatest vulnerability compared to the dark shaded areas, which is a time of lesser vulnerability. And therefore, the evidence and the recent studies suggest, and they are consistent, they point out the fact that the infection that occurs early in the pregnancy, in the first trimester, or the peri-conception period, is actually the one that matters, is the one that more likely to result in significant harm and disability to the baby. What about fetal abnormalities? And of course, if you do the ultrasound scan or the MRI, and we see that there is severe brain abnormality, that means that there is a high chance that the baby will have significant disability. Fortunately, the opposite is true. So if we do the detailed ultrasound scan and MRI and we don't see any brain abnormalities, that means the chance of disability is very low indeed, except for the chance of hearing impairment or hearing problems, because we can't see that on the ultrasound scan or the MRI. The other important thing is that sometimes the ultrasound or the abnormalities are not obvious early in pregnancy, and they become obvious later in pregnancy, sometimes 12 weeks or even later from the time of the mother's infection. And therefore, it's important that we keep monitoring this pregnancy by doing detailed ultrasound scan and MRI, and even repeating the MRI throughout the pregnancy. What about the laboratory test? So for example, measuring the amount of virus or the viral load in the baby's blood or the amniotic fluid. So we know that the higher the viral load, the higher the chance that the baby will be affected or have severe symptoms. And also measuring the platelets, it's the cells in the blood that helps to reduce the risk of bleeding. And we know that the lower the level of the platelets, the higher the chance that the baby having symptoms or having problems at birth. And therefore, what we do is that once we do the detailed assessment of this baby or this fetus, we triage this fetus into one of the three categories. Almost, I use the traffic light system. So green, that means asymptomatic. There are no abnormalities in ultrasound scan or an MRI, and usually the outcome is good, and there's a high chance this baby will have no problems. The red or the severe, that means that there is already severe brain abnormalities on the ultrasound scan or the MRI. That means high chance of disability. And in the UK, we would offer the parents the option of termination of the pregnancy in view of the guarded prognosis. And the group in the middle, which is the mild to moderate. And this is a tricky group because there may be some abnormalities on the ultrasound scan, but they're not severe. They're not certainly would result in disability after the baby is born. And this is a group where your doctor might struggle to actually be able to give you an accurate prediction about whether the baby will have disability or not. So the question, can we actually offer treatment? Can we do something to improve or to reduce the chance of baby having this potential harm or damage by the virus or being symptomatic? And this is mainly really for the group that's in the middle, the mild to moderate group. And there is some evidence that actually using the valacyclovir, the drug that I mentioned earlier, with the same dose could potentially help in this mild to moderate group, the one in the middle. This French study reported that actually giving this drug increased the chance of being asymptomatic, so have no severe problems at birth, from about 43% without the treatment to about 82% with treatment. So it's likely it looks promising and it might be effective. However, it's important to mention this was not a randomized controlled trial. This is not the best quality. And therefore, the current recommendations, the current guidelines do not recommend routinely giving valacyclovir to pregnant women. What the study was really useful is to provide data on safety. So we know that this drug, even in this high dose, it seems to be safe to give in pregnancy. The mother tolerated this high dose very well, and there were no harmful effects on the baby. What about the immunoglobulin, or this is antibodies against CMV. And again, the initial studies were very promising. It showed that it reduces the chance of the virus crossing the placenta from the mother to the fetus. And it's also, even if the baby is infected, reduces the chance of having symptoms or having harm because of the virus. Having said that, when actually randomized control trials, when the high quality studies were performed, that was not the case. Immunoglobulins were not shown to be useful in these pregnancies or in these babies. And in fact, it might actually have harm by increasing the chance of prematurity. And therefore, current guidelines do not recommend giving immunoglobulin to these women or these babies, apart from in the context of research studies. So my final my final slide is to summarize what I mentioned. Prevention, yes, we have good quality evidence to say that if the mother get the infection, CMV infection for the first time early in pregnancy, that giving valacyclovir with this high dose reduces the chance of the fetus being infected. So that's prevention of congenital CMV infection. What about if the fetus is already infected? So you have proven fetal or congenital CMV infection. In this case, what we need to do is to do the detailed ultrasound assessment with MRI, follow up during the pregnancy, and then triage these pregnancies into one of these three groups. The asymptomatic, the green, good outcome, and therefore we just monitor until the baby is born. The red, severe symptoms, high risk of disability. And in this case, either we monitor during pregnancy or the parents might decide to terminate the pregnancy. And the group in the middle, which is a mild to moderate, this is a group that we might consider treatment, for example, with valacyclovir, and monitor looking for abnormalities. And of course, once the baby is born, we will send the placenta for examination and then assess the baby, detailed assessment to determine whether actually the baby needs treatment after birth, like what I heard from Paul earlier. I'm going to stop here. Thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Asma. Fascinating. So we'll come on to questions right at the end in the Q&A, but if anyone has any questions, please do paste them into the Q&A at the bottom of the screen. I'll either answer them live or at the end, or possibly both. So I'd like to move straight on now to testing for congenital CMV, first during pregnancy. And I'd like to move to Sheila Dollard from the Centers for Disease Control and Prevention from Atlanta, USA. Thank you very much.
Thank you very much, Mike, and the other organizers for including me in this great session. So I will be talking about testing for congenital CMV during pregnancy. The basics of congenital CMV, that the audience may know much of this, but it's a very common, very highly prevalent virus worldwide, and it's generally not harmful to healthy people. Severe outcome of CMV infection can occur with pregnant women. And it can cause a primary infection is the very first infection that someone acquires of a given pathogen. Non-primary infection is when people can become reinfected with the same pathogen later. So primary infection of the mother during pregnancy generally causes more severe outcomes to the fetus, but also my talk is going to focus on diagnosis of primary infection because there's no easy way to diagnose secondary infection. So it affects about, in developed countries, it affects about 1 in 200 to 250 infants, and about 15 to 20% of them will have permanent disabilities. And the most common one is disability is hearing loss. And there are this little toddler in the pictures, you can't see it probably, but he's wearing hearing aids. But there's also varying degrees of intellectual and physical impairments. types of CMV tests during pregnancy. Now, testing of the mother is serology testing. And again, you're looking for the presence of different kinds of antibodies to CMV that indicate primary infection, because what I said was that there is no easy way to diagnose secondary infection. And then testing of the fetus. There is ultrasound, mainly ultrasound imaging and amniocentesis. I did make some slides on those, but I will skim over those because Asma Khalil just did such an excellent job of covering that in depth. Here's a table showing serology. Now, my lab does we do diagnostics for CMV. We do all kinds of PCR and serology. There's 3 main antibodies that are commonly measured, so 3 ways to diagnose primary infection. And the main one, the most clear-cut, reliable way is to show IgG seroconversion in a mother. And what that means is you have a pre-pregnancy negative IgG test, and during pregnancy, you acquire IgG and should have a positive test. IgG tests are widely available. They are rock solid. They're excellent. Most commercial tests are very reliable. The problem here is very few women have a IgG test done before they become pregnant. So using this to identify primary infection has low feasibility because of the lack of a pre-pregnancy serum result. Now, IgM is synthesized. It's not a reliable marker for primary infection. IgM antibodies are synthesized after primary infection, but they're synthesized many other times during a person's life. And they also are prone to false positive results, meaning that you can have a positive test result and it's not real. IgM can cross-react with other biomolecules in your blood. At the CDC, we get a lot of questions from healthcare providers. And the most common question I get for CMV is, what do I do with a positive IgM result in a pregnant woman? And I usually get a lot of other information. There's no cut and dry answer for that. Now, IgG avidity. When your body makes IgG to an infection for the very first time, the IgG has different characteristics, different physical characteristics for a few months that are easy to measure. And it only happens with the first infection. So this is theoretically a good way to measure primary infection. But the problem, the tests aren't really ready for prime time, in my opinion. My lab does a lot of avidity testing. We run 3 commercial tests I like to have the same result on all 3 tests, but I need the same result on at least 2 tests to report the result. So they don't agree. We've done a lot of it. We even have an in-house test, but the literature will say, and my experience is the same, that avidity testing is not quite standardized enough to be used in routine clinical care. But I think, in my opinion, going forward, if we want to try to diagnose primary CMV infection in pregnant women, IgG avidity has the best potential. And also, physicians can have results for all 3 of these tests and use them in combination, and they can be more reliable, but that's not practical for routine screening. That's a lot of testing, and it's IgM and IgG avidity have a lot of gray areas, so you really have to know how to interpret them. I handle these every day. This is the most common serology test in diagnostic laboratories. It's called a 96 well plate because it's 8 rows by 12 rows, which is 96. And the reaction in the well, the darkness of the color is generally proportionate to the amount of antibody. So each little circle is a separate specimen, and you can run about 80 specimens in one plate. So they're very efficient, very cost effective. And along the bottom, the clear fluid is negative, and in the middle, light blue is low levels of antibody and the dark blue is higher levels of antibody. This is just, it's the workhorse of most diagnostic labs. Now, testing of the fetus. Yeah, again, this was covered very well, but I will just say so there's ultrasound imaging, which is quite standard for pregnant women. It's not super sensitive at detecting abnormalities from congenital CMV infection, but it does help identify early problems. And amniocentesis is where a sample of amniotic fluid is removed and tested for CMV DNA by PCR. My lab does that, and the most common reasons, you've all heard of amniocentesis to test for Down syndrome or fetal lung maturity to see if a premature baby is ready to survive outside of the womb, or in this case, to diagnose fetal infection. It does carry a risk of leaking amniotic fluid, a low risk of miscarriage, but it is the preferred method for identifying fetal infection. So should pregnant women be screened for primary CMV infection? Currently, to my knowledge, there are no medical associations or congenital CMV recommendation groups that support universal antibody screening of mothers for two reasons. As I was describing earlier, there's really no clear testing algorithm right now to demonstrate primary infection in pregnant women. And then secondly, there's not an effective treatment. So if you did diagnose primary infection in pregnant women, there's not clear treatment to reduce the risk of the mother passing that infection onto her, clear, effective treatment to prevent the mother from passing the infection to her baby. So again, this was covered, but hyperimmune globulin showed promise for a while. To date, there are no randomized controlled trials that show that it's effective. And the antiviral treatment is promising, but probably not ready for, as the asthma said, not ready for routine clinical use. Vaccine development, several companies have candidate vaccines, some in third phase 3 clinical trials, very promising. Right now, there's no vaccine. Okay, thank you. That's it for me. That was quick. I'm finished.
Thank you very much, Sheila. Really interesting. Thank you. So I'd now like to move on to Soren Gant from the Université de Montreal in Canada to talk about testing for congenital CMV in newborns.
Great. Thank you very much. It's really a pleasure to be here and talk about newborn CMV screening. I'm going to disclose that I receive research funding and consulting fees from a number of companies related to CMV vaccine development. So just generally, newborn screening refers to a public health program that systematically tests newborns for specific diseases that are not clinically evident at birth, and that's intended to allow for early beneficial interventions. I'm summarizing the criteria for newborn screening here, which vary depending on where you look, but basically it boils down to the requirement that a disease is a significant public health problem, that the natural history of the disease is understood, evidence that screening improves outcomes of babies with that disease, that there are resources available for care of babies diagnosed through the screening program. The program should not cause harm, and most places want to know that it's cost effective. So this horrible picture is what you'll see in textbooks and what doctors learn in medical school about congenital CMV. And a baby like this would not be missed. This baby would be diagnosed with congenital CMV. But as you've heard already, the vast majority of babies with congenital CMV infection look completely normal. Either they're asymptomatic, like 90% or so, or their symptoms are subtle and not recognized as being congenital CMV. And so what we know is that only about 1% of all babies with congenital CMV are diagnosed at birth without a screening program. And the reason this is important, again, you've heard nicely already, is that the risk of problems later among asymptomatic kids is quite high. So it's around 15% or so of asymptomatic babies that'll develop hearing loss, as shown here. And this primarily occurs in the first couple of years of life when babies are most rapidly learning speech and language. And so if hearing loss is not identified during this period, they're only recognized as having a problem when they miss their milestones, and by that time it's often too late to catch up. So that's why diagnosing CMV early is beneficial. You heard about antiviral treatment for selected newborns who have symptoms of congenital CMV and how that helps their hearing and probably development if started in the first month of life, but we don't have evidence for that if they're treated later. And then probably most importantly is that regular hearing tests and identification of hearing loss early allows intervention with hearing aids, cochlear implants, speech language therapy, whatever that child needs to help them meet their milestones and achieve the same developmental outcomes as their normal hearing peers. And because of the ability to provide these benefits, most studies that have looked at CMV screening programs or other prevention interventions suggest that these are highly cost effective, acknowledging that real world data about costs are lacking. So diagnosing CMV in a newborn requires finding the virus by PCR, and everybody knows what that is now because of COVID, in a sample that's collected at less than 3 weeks after birth. And that's because if you find the virus later, that could represent a postnatal infection, not a congenital infection. Saliva or urine are the recommended samples. Again, as you saw, because there's so much more virus in those samples than in blood. Dried blood spot, using the most sensitive methods is only about 80% sensitive for finding congenital infection, meaning about 20% at least of babies will be missed using this approach because there's less virus in the blood. The advantage of dried blood spot is that it's already collected from every baby, pretty much every baby born in high resource countries. And that means it's a lot easier to use that sample for a CMV screening program. That those samples are already tested for other diseases for newborn screening. It's not to say that it's impossible to use saliva or urine for screening. They're easy to collect. It's just it requires organization and investment to set up use, collection, and testing of those new sample types and programs. The two general CMV screening approaches for newborns are so-called targeted CMV screening, which is done more and more in North America and Europe. And I should say that all screening programs that I'm aware of have either been initiated by or promoted by parent and family advocates and foundations, and this has really increased the uptake of screening programs internationally. But targeted CMV screening is actually case finding or testing based on risk factors, primarily the failed hearing screen at birth. And so this misses a lot of infected infants namely those who don't have hearing loss at birth. But it finds a lot of kids. It's much better than nothing, and I would argue that it's the minimum standard of care. The other approach is universal newborn screening, which is testing all babies who are born, which has the potential to identify all infected babies. One of the concerns about this approach is that it finds a lot of babies who will not develop disease. Around 80% or so of infected babies won't have any problems from the infection. And so how do you deal with those families? There are very few universal newborn screening programs. The only large one currently in place that I know of is in Ontario using dried blood spots, although soon there will be programs in Saskatchewan in Canada and also Minnesota in the US. So after a positive test, you really need an organized system to follow up positive tests and provide the appropriate care and support. And counseling and education of parents is absolutely critical for any screening program, and in particular for CMV, because as I mentioned, a lot of these kids won't have any problems. And this is kind of a nuanced discussion to prevent undue anxiety, but also to make sure that kids get appropriate care. It involves pediatrician visits, eye exams, hearing tests, brain imaging, blood tests, again, to determine if antiviral treatment is necessary in the first month of life. That requires a lot of organization. And then regular hearing tested for all infected kids until about age 6. So that's a lot of hearing testing and personnel to be able to accommodate that. However, I should say that for other conditions that are screened for, this type of follow-up is done very well, and the program in Ontario shows that it's feasible for CMV. This is the Ontario screening program's follow-up algorithm from their website, just showing that there's confirmatory CMV testing, blood tests, a physical exam, head ultrasound, hearing testing, and eye testing, all within the first month to be able to make decisions about appropriate care. So to return to these criteria, it's clear that CMV is an important public health problem. We understand the evolution of the disease and the risks to these babies. I would argue that there's good evidence that finding congenital CMV infection early in life improves outcomes. There are available resources for care, but it should be stated that really setting up a program is a big deal. It takes a lot of infrastructure and investment. Some people worry about the impact of families of giving a baby a diagnosis of congenital CMV. I would argue that most families want to know, and that this benefits babies, and that with appropriate counseling and education, this can be done very well. And finally, I think it's likely that screening would be cost effective, but we need more data from real world programs. Thank you very much.
Thank you very much, Soren. Really interesting. So finally, before the Q&A, I'd just like to move on to Paul Moss from the University of Birmingham to talk about vaccines. And just to say, if you've got any questions that you want us to address in the Q&A right at the end, then please do start typing them in now, and we can get on to chat about that. Over to you, Paul.
Thank you, Michael. Super session, really, really important. Thank you very much. Let's close that off. Right, so as Michael says, I'd like to talk about vaccination against CMV and really introduce a little even more about the immune response to this virus, which is so critical in controlling it. I'm at the University of Birmingham. I should say I've not been directly involved in vaccine studies against CMV. Paul Griffiths has on the panel, and we'll probably talk to Paul. And I also don't have any conflicts of interest. So just what I'll outline is the immune control of CMV, how we fight it in health and disease, talk about some of the clinical areas and the need for the vaccines. What's driving that? Approaches to vaccine. What are the approaches we can take? Some of the successes so far, although as we just heard from the speakers, we don't have a licensed vaccine available. And then the future potential. We're all very excited. And of course, you won't be surprised to hear that I'll point to some of the vaccine successes in the last 2 years about why we're excited about vaccines. So this is the problem we're dealing with, cytomegalovirus. That's a picture on the left. That's the capsid, that's the protein that core, and the DNA is inside there. And those little holes are where the DNA is pushed inside this protein core. And that protein shape is the same for 8 different types of viruses, these so-called herpes viruses. I think people, when they hear that, they think of, herpes simplex, don't they? Cold sores, things like that. But these are incredibly important viruses. And you might have heard a couple of weeks ago, there's a lot of interest in that one of them, Epstein-Barr virus, causing multiple sclerosis. So I think there's a lot of surprises about these viruses that we don't yet understand. Now, what's important about these herpes viruses is once you get them, you never get rid of them. It's pretty startling, isn't it? If you think about influenza, SARS-CoV-2, COVID, those are short-term acute viruses. We clear them. We might get them again. We often do, but they don't live within us. But this one is persistent. And these viruses, they somehow go to ground sometimes. They might evade the immune system and go quiet. Others, such as CMV, may constantly be provoking the immune system and challenging us. More about that in a minute. Now, one thing that's really quite important to remember is that this infection is incredibly common. What's the global population? About 7 billion people. By far, most people have got CMV infection. And if you look around the world, you'll see different geographical rates. So across Africa, Asia, Europe, almost everybody has got CMV infection during their lifetime, this is, but often very early in life. And throughout our development as a human species, it's 200,000 years since our species has been going. CMV has been around. It's infected almost every human being during evolution. And most people get infected in their first year of life, probably in many parts of the world. This is a graph. Let me explain this graph. This is from sub-Saharan Africa. It's Malawi, I think. And this is 1 year. This is in the first year of life of these children. And this is 100% infection rate. And you can see that within the first year, these children almost all getting infected with CMV. This is not congenital infection so much. I mean, there will be some cases, but we'll talk about perhaps why not in a minute. But these are post-birth acquired infections. Now, this is probably the safest way to get CMV. This is probably what our evolutionary immune system has coped with, because at this stage in life, it's not thought to cause too many problems. It's, of course, prior to birth, where we've just heard, you can get severe problems. But one of the challenges that we have now is that CMV is getting less common, and I'll explain why it's a challenge in a minute. If you look at Europe, I mean, sorry, this slide is a little complex to understand, but basically this is people 10, 20, 30, 40, 50 years, and this is the rate of CMV in them. And you can see if you look between 1991 and 10 years later, it's dropped by 10%, and it's gone down ever since. And so, people like myself and Mark Wills and Paul Griffiths who work on CMV, and you used to we'd bleed ourselves in the lab and our lab donors looking for CMV responses. And what we found, even in my time, over 20 years, is the number of young people in the lab whose CMV seropositive is dropping. Now, you might say, why is that? It's an interesting question. I mean, the way CMV is transmitted, generally maintained, is probably through breast milk. Because that's a very good way for a virus to transmit, because that's obligatory throughout evolution, that breast milk's kept us alive. But perhaps, the block of breast milk transmission, maybe formula feeding and so forth, has had a big effect here. But anyway, CMV is less common now. You might say, of course, we might say this is a good thing. But of course, the problem then is that if you look at this age here, 30-year-old in women, you've now got half the women who have not got CMV, but they are susceptible to then getting CMV for the first time when they're pregnant. So you can see in a population, let's say in Africa, where this graph is 100%, women at that age are already infected, and therefore you've got a slightly different problem. So the epidemiology is important. So how do we cope with CMV? It's prevalent across the world, or it's a pathogenic virus. This is not a mild virus. So how do we cope? We cope through our immune system. So there's, I've done a pretty poor picture of a cell there, and there's a virus inside, and the virus is constantly trying to challenge us and replicate. But our immune system, our cells of our immune system, and also the antibodies of our immune system fight it. And, CMVs help to drive the evolution of our immune system. The reason we have these cells is partly because we've been fighting CMV throughout our history. And so these are incredibly important. And as Dr. Gantz said, we all know about these cells now, don't we? Antibodies and cells over the last 2 years, so the public knows all about them. So CMV can become a problem, and it becomes a problem when this balance with the immune system is disrupted. And that's, as we heard this first session, particularly with infection of the fetus, with an immature immune system, as we heard very nicely from Dr. Khalil about how in the first trimester, when the immune system and the organs are just developing, this is when you get really big problems. And so this occurs when a mother becomes infected with CMV for the first time during her pregnancy. She doesn't have strong immunity and transmits it. The other area where CMV is a problem, and it's really underestimated throughout the world probably, is when people are immune suppressed. And this could be due to a disease such as HIV, untreated HIV, this is. Treatments are actually very good, but when HIV came along, we didn't have a treatment. Had all sorts of problems with CMV, including a lot of eye disease. And unfortunately, people went blind because of CMV infection. But probably more common these days is because it's not the disease, it's the drugs that doctors give to people, particularly when they've had something like an organ transplant, a kidney or a liver or a bone marrow transplant. And these patients are very immune suppressed and highly susceptible to CMV problems. And Paul has done some work himself on that and may comment on that. So these are where we might want a vaccine. So we do need a vaccine. Now it took a little while, but certainly in America in 2000, the National Academy of Medicine made this a priority, and that seemed to spur a lot of interest in developing CMV vaccines. We don't have one yet, but we have interest in it and a lot of developments. And this vaccine could either do two things. It could stop infection occurring at all. I mean, I've said here, obviously we want to stop women who are childbearing and never had CMV from ever getting it. This is where the great excitement is. And I suppose, why couldn't CMV and a vaccine one day be incorporated into childhood vaccines very early in life? That would be the ideal, wouldn't it? And then you'd never get CMV in your life. That's the dream. We're some way off that. The other area where a vaccine might work, and it's in a slightly, well, we're used to it now, but it's boosting the immune system when you're already infected. So as I've said, if you've got CMV and you have to have a kidney transplant, let's say, what about a vaccine to boost your immune system, to fight CMV and to stop you having problems? It's a bit like the booster vaccines we're having now against COVID, of course, but that's not a chronic infection, as I've said before. How are we going to do that? Well, over the last 30 years or more, it shows the importance of basic research, lab research. We're starting to understand the immune response to CMV, and we can either get vaccines that make antibodies, all those things that we're interested in measuring in ourselves against COVID now, that neutralize the virus and stop infection. The major protein here is something called glycoprotein B, which is important on the surface of the virus. And you can imagine that these antibodies stick to that and they gum up the virus, they neutralize it, and it can't infect you. And the dream is that this vaccine would produce, as I say, neutralizing infection and stop you ever sterilizing infection, stop you ever being infected. There's also another protein complex, pentamer. The clue's there. It's a combination of 5 proteins. That's also very important in stopping the virus sticking to your mouth and getting infected. When I talk about the Moderna vaccine in a minute, these are the proteins that they are targeting. But you can also induce a cellular immune response. If the virus is already in your cells, you've got a bit of problem because it can hide inside your cells. And this is where our cellular immune system is important. So those are the sort of things that people are putting into vaccines. But a CMV vaccine is a challenge. Why? Well, here's some things. We know that people who are infected with CMV already can get reinfected. You can have CMV for 20 or 30 years and then get another strain of CMV. And that is disappointing because that shows that you've not got preventative immunity. So what on earth does that mean? Also, as we heard from the earlier speakers, sometimes pregnant women who are already gotten CMV, such as those women, as I talked about in Africa, where infection rates are very, very high, can sometimes still pass virus to their fetus. But obviously, it looks as if this is less common and less severe in terms of outcomes. But that's something that others on the line, more expert in this area, can address. And then finally, the complexity of these studies. If you want to vaccinate men and women, and particularly women, of course, in terms of pregnancy, and then show a reduction in clinically significant congenital infection subsequently, that takes many years and a very great deal of money because these are complex studies. We'll talk about that a little more. So what sort of vaccines are people developing? It's an interesting story. I'll take you through some of the history. It's always lovely to see where our science comes from. In the early days, they injected a mild form of natural virus. They were actually quite good. I'll show you that in a minute. A safer thing, you might say, is just to inject proteins of the virus. We'll talk about that. A very promising virus at the moment is one that can infect you and start to grow, but it can't spread. So it's not dangerous, but it just gets going. And then finally, we all know about mRNA vaccines. Are they the solution for us with CMV as well? Let's have a look. Now, vaccines can work in terms of the immune response and the clinical effects. In the 1970s, they started on CMV vaccines and they grew mild forms of CMV. Great paper from Stan Plotkin, who's still a major name, still publishing on COVID vaccines. And he took a virus from a child with congenital infection. Right, comes full circle. And he took this virus and he grew it in the laboratory 150 times until it got weaker and weaker and weaker. And then he injected it in people to see if they could induce an immune response. And it did. And in the 80s, this was actually used to help transplant patients. So, it seemed to be quite helpful. And in the 1990s, people were starting to be injected with this protein because that was felt to be safer than using the whole virus. And this was a very important paper 12, 13 years ago now, where this protein, glycoprotein B, was used in women of childbearing age. And this is what we call Kaplan-Meier. It's looking over 3.5 years. at the number of women who got CMV. They were all negative at the start, and it was given to women within a year of giving birth. And you can see that the vaccine kept more people above the line, whereas the placebo, this was a drop-off of the women getting CMV, perhaps from the nursery where their child was going to. So it was a 50% protection. Overall in this study, there was 1 congenital infection in the vaccine group and 3 in the placebo group. So, it was great, it was exciting, and people, scientists and clinicians and the public were excited, but it never really was enough to go into full clinical therapy on the basis of the power of these. And Paul did a great study, who's on the line, of this vaccine in transplant patients, and he showed that this could also produce very good antibodies. This is the antibodies in transplant patients before the vaccine. These people had never had CMV before, and it pushed up the antibodies. And even in people with CMV who got antibodies, it boosted them. And Paul showed that this actually reduced the amount of time that the virus was in the blood. So this vaccine, the so-called glycoprotein B vaccine, is a good vaccine, but it isn't good enough. And so we've now got some more recent vaccines. And this is one I'll tell you about in a minute, the V160. It's one of these replication deficient vaccines. It goes into you, but it can't divide. Sanofi are updating their glycoprotein vaccine. Paul may know more, adding new adjuvants, proteins that stimulate immunity, adding new proteins. And then there's Moderna as well, and I'll talk about their vaccine in a minute. Now, this I saw as an abstract last year. This was the V160 vaccine from Merck, Sharp and Doe. And this was used in a very, quite a big study, over 2,000 women. And they received 2 or 3 doses of this vaccine, again, about 0, 1, and 6 months. 2 doses weren't any good. 3 doses did reduce congenital infections, similar amount, again, 42%, but according to how this trial was set up, this didn't reach the endpoint of the trial according to this abstract. Now, the vaccine did reduce the amount of virus present in congenital infection. So even though it didn't actually stop the infection, it may have reduced the virus and perhaps the severity. So that may be useful. So there's more work to do here with this vaccine. Now, as I've referred several times, vaccines are now central stage. These are the 3 big COVID studies. This is Moderna's. This is number of people getting COVID infection in a control group versus the Moderna vaccine, 93%. This is Pfizer, 93%. Pfizer, this is the AstraZeneca, again, very effective. We've got used to these numbers, 90%, if only we could get that. And this will drive innovation in CMV vaccines. We've got new technologies. We've got mRNA and adenovirus. They're really, really immunogenic. And money is available. Moderna has gone from a startup in 2010 to one of the wealthiest biotechs in the world. And so public trust and confidence in vaccines is also very high. So where is this going to take us? This is one we're going to hear at the meeting tomorrow, an update from Moderna. It's their mRNA 1647. It's now going into nearly 7,000 women of a range of ethnicities across America and beyond. And it's a lipid nanoparticle, consists of 6 different mRNAs making up that pentamer and glycoprotein B. And this is being assessed for its immunogenicity and adverse effects. And CMV is one of the major targets of the Moderna Corporation. So in summary, CMV vaccine remains an unmet medical need. I've been convinced in a very powerful way over the last hour of the need for that more than ever. And studies of the science of immunity mean that we know the targets. Vaccines are immunogenic. The trials are complex and expensive. But I hope, I'm confident that this can be achieved with all the improvements in vaccine technology we've seen over the last 2 years. And I'll stop there, Michael, take some questions.
Excellent. Thank you very much, Paul. So if all speakers could turn their videos and sound on if possible, then we'll go through some questions. And please do, if you're participating, then please carry on putting any questions in the chat and we'll try and answer some things live. So Firstly, I'd just like to start off by going through a few questions we've either had in the comments that people actually put in when they registered, and also live online, and just a few questions, clinical questions really, from parents of children with congenital CMV. And just to remind everyone where we're at, just firstly a case study that's been partly answered in the chat, but this is from two parents of a 3.5-week-old child with congenital CMV. Mum developed CMV in the 3rd trimester, and the baby's urine and blood was positive at day 1 and day 7 after birth. However, fortunately, they're asymptomatic, they have no symptoms, and they've passed their hearing and vision tests. And so the questions from the mum and dad were, would treatment help? And it's difficult, is it? Because there's no real baseline to compare against. And finally, how often to carry out hearing tests in the future? So please do jump in if you'd like to address any of that.
So I think I mentioned in the chat, there's currently no evidence for antiviral treatment being beneficial in asymptomatic babies. You know, that's not to say that it's not beneficial, but we just don't have any evidence for that at this time, and so it's not currently recommended to treat asymptomatic babies. What is definitely beneficial is to follow the child with frequent audiologic testing, and the frequency that different programs do that varies by program, but typically it's at least a couple times a year for the first couple of years, and then at least yearly until school age. So you know, I would just check in with the audiology specialists at your center. The fact that that your baby is asymptomatic at birth is obviously a good thing, and the fact that the infection occurred late in pregnancy is also a good prognostic sign. So.
Excellent. All right. Well, thank you very much. I'd actually just like to move over to Hermione Lyle, who's just raised her hand, and I can actually allow people to talk. So I will just bring her on now. Ryan, if you could unmute and then just ask your question or make your comment, please.
Can you hear me?
Absolutely. Yeah.
Yeah, my name is Hermione Lyle. I'm a pediatrician working in Peds ID in London, and I just want to make sure, because in the UK we don't know exactly when infection has happened in pregnancy necessarily. So I think it is really important that this little baby does get a proper assessment by an infectious diseases pediatrician, and that if the baby has failed the newborn hearing screening, it's also important that the baby gets proper audiological testing just to be absolutely sure that the hearing is normal. And also in the UK, we would normally offer babies to have a brain MRI scan to see that the brain tissue is normal. So I think before saying the baby is asymptomatic, it does need to have a full and proper assessment. I just want and if CMV Action, the team will know, depending on where the family live, what would be the most appropriate specialty team that could support Ian's daughter.
It's an excellent point. Yeah. So as I mentioned in my talk, you know, really to do the proper workup, it requires audiologic, eye testing, brain imaging, blood work, and a good exam. So absolutely, if the child has not been fully evaluated, for sure that needs to be done. Thank you.
And just at this point, it seems we've raised the issue of brain imaging to emphasise what would be done if the brain imaging was abnormal in some way.
So it depends on the findings. If it's a convincing abnormality associated with CMV infection, consistent with CMV cytomegalovirus inclusion disease, that would merit antiviral treatment. So MRI is kind of a controversial question. The standard initial assessment is by cranial ultrasound, because I think we have a better handle on what the findings from cranial ultrasound mean in terms of risk of subsequent disease. And MRI finds a lot more potential abnormalities that may or may not end up being clinically important. So it's not to say that an MRI is inappropriate. It's just it's a little bit more nuanced.
Okay, excellent. Thank you very much. Would anyone else like to jump in on this question at all?
Just that I did put a link to something that can be downloaded from the website with what the guidelines would be here in terms of monitoring.
Fantastic. Thanks very much, Sarah. And Hermione, any other comments at all?
Well, I suppose that actually in Europe we do brain imaging with MRI more often than in the Canada or North America. And so we would include that as part of our baseline, particularly because of the fact that we don't often know about the timing of seroconversion. And I think that one of the issues about cranial ultrasound is it doesn't necessarily pick up neuronal migration abnormalities very well. And neuronal migration abnormalities are the ones that are usually associated with early infections, so either in the first or early second trimester. And we find those kind of abnormalities, we know that the baby is more likely to have difficulties as it grows and develops. So I think it's important to include an MRI scan if you can.
Yeah, and again, that people disagree about an MRI scan in a baby with an otherwise normal workup, but again, it's reasonable. You know, neuronal migration disorders are rare in babies who are otherwise normal and have normal cranial ultrasounds. But again, I think that I know that is done some places as first line.
Excellent. All right. Well, thank you very much. That's very good. Hermione, I'll keep you on the line in case you'd like to join in later as well. So another clinical question. So to what age is deterioration in hearing a possibility? This is someone who says, my daughter was born with congenital CMV and has mild unilateral loss and is 11 months old. Would anyone like to address that? Anybody? Soren or asthma at all?
Sorry, the baby's 11 months old with
mild unilateral loss. Yeah.
Yeah. So again, in terms of treatment, you know, at that age, there's no evidence for antiviral treatment, and care consists of regular audiologic follow-up and speech language therapy, and evaluation to determine, you know, what might be of benefit in terms of developmental therapy and support. So there's no, you know, whether or not hearing amplification based on the degree of hearing loss would be indicated now. I doubt it, but that would be up to the audiologists and potentially the ear, nose, and throat specialists.
Okay. All right. Thank you. And so let's move on. There's been quite a bit of debate about should we be testing during pregnancy. So now we obviously have randomized controlled trial evidence of an effective intervention to reduce transmission in the first trimester in the form of valacyclovir. Should we actually now introduce this as well? We've seen newborn screening programs, but should we introduce a pregnancy-based screening program and other things we can talk about? If so, when should we screen exactly during pregnancy? How often should we we do it more than once? And if we're just going to stratify people, should we risk stratify people we should screen? Just throw this open to everybody to comment on.
Maybe I would start. I mean, the screening for CMV during pregnancy, it's a controversial, and as Dr. Dollard mentioned, it's not recommended in most countries, and there are very few countries where actually CMV testing is common during pregnancy, like Israel, for example, like Italy or Belgium. I mean, certainly the evidence on novel acyclovir from randomized control trial from Israel is very, very promising. The question, if you go to the National Screening Committee and propose that that's enough evidence to introduce screening pregnancy, I suspect the answer would be no, for a number of reasons. It's a single center, whether they would want to have a larger multi-center study, or maybe in a UK healthcare system where, as you would expect, sort of the National Screening Committee want to look at various aspects of implementation of a potential screening test in a UK setting. The other thing is that means you need to, because the trial shows that this is beneficial for women who have primary CMV. Well, what about the secondary CMV, which is actually the majority of congenital CMV infection? These babies are born to women who had secondary CMV, not primary. And the other thing is that if you would test during pregnancy, at what stage would you test? Because that the booking test, also the first visit for the patient with a midwife, usually takes place about less than maybe 10 weeks, before 10 weeks during the pregnancy. Would that be enough? Do you need to repeat the test again at maybe a later stage, maybe a few weeks later, because you're likely to miss some of the one who actually did have primary CMV infection in the first trimester? And then furthermore, I think there's another issue, having had experience myself when we did the Race Fit trial or study where I work at St. George's, is that when you do first trimester screening or you test, there will be some women who the results are not straightforward, and therefore you concern about maybe unnecessary anxiety, maybe further testing, because if you want to make sure that there's no congenital CMV, you will end up by doing amniocentesis. So I don't think it's as straightforward. I personally would love to see that this has been implemented and see that women are actually offered the opportunity to have testing. But my gut feeling that the National Screening Committee will not recommend it yet.
Okay, Soren next.
Yeah, so I agree. In Canada, we have recommended testing for high risk moms. So pregnant women with a toddler in the home and some other risk factors. One of the concerns I think that we discussed in developing the Canadian guidelines was the possibility that serologic testing during pregnancy that finds a woman is CMV seropositive could be falsely reassuring to women, because the risk of having a baby with congenital CMV is actually higher among seropositive women than seronegative women on average. So although a seronegative woman that acquires a primary infection during pregnancy who seroconverts is at very high risk of having an infected fetus, on average, being seropositive is a higher risk, because those women, probably in part due to reinfection, they're exposed to CMV. That's why they're CMV positive in the first place. So we don't want to mistakenly reassure women. We want seropositive and seronegative women to be aware of CMV and to avoid risks of acquiring CMV during pregnancy through all the behavioral modifications that Sarah and Sharon mentioned nicely.
Great. Sheila, do you want to say anything on that topic at all?
Yeah, sure. Yeah, I agree with, that's a good point that I don't think has come up yet that Soren just made is another reason to not do universal serologic screening of pregnant women is because you can only diagnose primary infection, seronegative, seropositive, and then seroconversion. And the women who are already positive, they're at risk too, and they have a higher prevalence, a birth prevalence of congenital CMV, and they can have adverse outcomes too. So, but then back to my other point is when people say we should do, and high risk mothers would be okay because there would be many fewer, but the serology is not worked out. The serology right now is not great for getting a clear-cut answer on primary infection. So, over.
Okay, so in other questions that have come up in the chat are about PCR. So how about doing PCR in high-risk mothers to look for viral DNA in the blood?
So PCR in the blood, or like PCR in the saliva to show that they're shedding.
Or saliva, yeah, of course.
Yeah, well, pregnant women intermittently who are seropositive intermittently shed. I don't think there's any correlation right now between those results and even viral load within those results and risk of vertical transmission to the fetus. So I don't know what the physician would do with that information.
Yeah,
but
yeah.
Maybe the physicians can chime in, but I don't think that's useful right now.
I think it's tricky. It's true that saliva and urine detection don't correlate with risk of congenital transmission. There's some data that that viral load in the blood during pregnancy is associated with risk of congenital transmission. I think the problem is it can be transient, and the likelihood of finding it is quite low. And so it's probably a very low yield test in terms of a programmatic approach. The studies that have looked at this have really looked at women who with identified primary infection based on symptoms and serology and looked around the time of infection at PCR in the blood in that way. So I think operationally it would just be really challenging.
Okay, excellent. So over to Hermione first, then Paul Moss.
Well, I think in trying to be optimistic, we wrote to the National Screening Committee because they were asking for feedback on screening for congenital CMV earlier this year. And I think there are two really crucial points here. One, if a woman knows her CMV status, whether she's seropositive or seronegative, if she knows about CMV, she can take up the hygiene measures to reduce the risk of transmission, whether she's seropositive or seronegative. So I think women should have that option and that opportunity and that education about the virus, which at the moment they don't get anything at all. So that's an intervention that works for the seropositives and the seronegatives. I think for the seronegatives, it's the most dangerous time of getting infected is in the first trimester. That is when a baby can really be very seriously damaged. I think, in the Israeli study, they tracked these women very early on, and they did do samples for serological testing in the first trimester. So that does, many of our women don't present so early, so it would be tricky. But I think we have quite convincing data that we can prevent a serious infection. And if we don't get it to the point of offering that to all women, we should at least be thinking about how we put together a bigger pilot study in the UK and actually take this forward to look more closely at how we could actually make it part of clinical practice in this country.
Okay, excellent. So to Paul, who had a question, and then to Soren after that.
Mine's just a technical point, really. I don't want to distract too much, but Sheila, the IgM test, which you might have thought would be great because it is for so many other viruses, is really poor here, isn't it? What do we need to do to get a good IgM test for CMV? What's the problems that we're facing?
The main problems, and I don't really know other viruses really well outside of herpes viruses. I thought IgM was problematic for a lot of infections in that it cross-reacts. The with biomolecules, ANAs and rheumatoid factor. I know CMV IgM cross-reacts with those molecules, but I think that's one problem is a low-level IgM positive is not reliable. It's not specific. The other problem, though, is that it's resynthesized throughout life with reinfection and re-exposures. Okay. So did you think that with more refinement, IgM could be useful? I guess I've dismissed it, especially with the growth of avidity testing.
No, it is a problem for CMV, isn't it? I don't know, it says something about the virus, I think, that maybe low-level IgMs, as you say, are cross-reacting. Also, there is something about CMV, as you say, we can make it again with persistent infection, which is very unique, really, with the persistent virus. It tends to come just first, and then you rely on IgG. Okay. Anyway, that's something we can discuss this week at the science conference, but it's a very important practical problem, isn't it? Thank you very much.
Yeah. Mm-hmm.
Excellent. Then Soren, I think you had your hand up next.
Yeah, so I just wanted to emphasize what Hermione said. I think education about CMV during pregnancy and the fact that pregnant women can reduce their risk of infection or reinfection during pregnancy is key. And our Canadian guidelines really emphasize that and give tools about how to do that for practitioners. I guess in terms of serologic screening during pregnancy, I would argue that serologic screening is not required to provide that counseling and education. I agree with you that having that test result as a trigger to discuss the results and what they mean could be useful in terms of sort of making a concrete reason to have that discussion, but I guess if the serology result in and of itself was not necessarily useful in general, then that discussion could take place without the serology. To be totally honest, I think that there is a value in women in knowing that a woman is seronegative. And being able to identify if seroconversion occurs. I just think operationally it's challenging, and ideally risk stratifying is probably the way to go currently.
Asma?
I mean, despite the fact that I agree with some of the sort of the point that Hermione has mentioned, if I'm on the National Screening Committee, I would say, well, but all women should have, you should raise awareness, all women should follow sort of this hygiene. And in fact, you could argue that waiting until you assess the serology in the first trimester is actually a bit late. In fact, if anything, you really want to do that pre-pregnancy, and also you want to raise awareness and educate mothers about how to reduce the risk of acquisition of getting an infection in the first place. You probably should target women before they get pregnant, because I think by the time they're already in the first trimester, by the time they're 10 weeks, it's actually a bit late. And therefore, I think despite the fact that I agree with you, Hermione, that knowing that I'm seronegative might influence my behavior, I would argue, if I'm on the National Screening Committee, well, actually all women should have that. So actually knowing is seronegative and seropositive should not really make a big difference.
Excellent. So one more question on this strand. How about testing women as soon as their pregnancy test is positive? Then how about this is part of a campaign that you say, as soon as your pregnancy test is positive, go and get your CMV serology, and then in many that would be an estimate as to whether they were already seropositive or not, and then you could screen those people that were seronegative, and that would help educate everybody.
I personally think this is a much better approach, because you really need to try, if any measure, you need to do it very, very early stage in pregnancy.
Anybody else? Any more comments on this one? Okay, let's move on. Now on to someone who's immunocompromised. So moving away from congenital CMV, someone who's actually immunocompromised, and they say need to take valganciclovir every few years, presumably because of symptomatic CMV reactivation. And they say, is it possible to vaccinate for people who already have CMV, and want to know when we will know this? Because I suspect this may not be covered by the initial trials that are going on at the moment. Paul or anybody else, do you want to comment on this?
Yeah, I mean, I don't want to put Paul Griffiths on the spot, but you did that great study, didn't you, with the glycoprotein B vaccine and kidney transplants, wasn't it? Or was it liver as well?
Yeah, kidneys and liver. So the question from the audience, I think, is a great one, but I think they'll have to wait quite a long time for vaccines. What's going to happen is the vaccines are being done, as Paul mentioned, to try to prevent primary infection during pregnancy. And if that works, then that'll be fine, and the vaccine will be licensed. Then it will be studied for people who are already seropositive, already infected, to say, can it, quote, boost their immunity? And that's when the type of person you're talking about there might get involved in a study. But it's quite a few years yet before that comes through.
Okay, excellent. And Soren, comment from you.
Yeah, so the current CMV vaccine trials, so including Moderna and GSK is planning one as well with a subunit vaccine. They will include seropositive individuals, but they'll be healthy individuals to look at safety and boosting of immunity. Those trials will include measures of shedding in seropositive people. So I think, like Sheila mentioned, we don't have a great way of measuring reinfection, but looking at the effect of vaccination on shedding among seropositive people is one step toward that. But they're not being currently tested in transplant patients, although I hope that will happen soon. And just one minor correction, Paul, Dr. Moss, about your presentation. The V160 vaccine showed a 46% reduction in primary infection of women, not congenital infection, and so we'd love to have evidence that vaccination reduces congenital infection, but reducing primary infection is currently the goal. The good news potentially is that I think a vaccine may not have to provide strong sterilizing immunity to have a big effect on reducing congenital CMV, if, as you say, it's given to young children, and if vaccination of children reduced transmission to mothers because of, again, this important source of infection of pregnant women being young children. So I'm very optimistic about vaccine development.
Yeah, thanks for correcting that. Sorry, yeah, it's a bit like the glycoprotein one then, wasn't it? 50%. What do you think about the V160? I only saw the abstract last year. Do you think those data are good enough to take it to another stage?
So we just posted a preprint of a mathematical model. So I was involved in the V160 trial. It didn't meet its primary endpoint, but very much like the glycoprotein B MF59 construct, it reduced primary infection by about half. So that is not viewed as being effective enough to take to the clinic. But when we model this and we look at, and maybe Griffiths wants to comment on this too, but when we look at a vaccine that's sort of modestly effective to this extent, and we do in silico trials giving it to young children, what we find is that this has a dramatic impact in reducing the risk of infection or reinfection during pregnancy and of congenital infection. So I actually think the bar might be too high in terms of what we're looking for a CMV vaccine.
Yeah, I would agree.
Paul Griffiths?
Yes, I mean, Soren's raised a very good point. And Paul Moss mentioned that the Bob Pass 2009 New England Journal paper that showed about 50% protection. And this newer vaccine, the MSD one, has about perhaps 50% protection. I don't know why it's always 50% for the CMV vaccines, but it just seems to be in that direction. If we had an HIV vaccine that was 50% efficacious, people would be rubbing their hands with delight. The trouble here is that people don't think CMV is important. The epidemiology shows that the R0 value for CMV is actually quite low. So a vaccine, our estimate was about 60%, and the CDC thought about 50% of protection would be sufficient to drive herd immunity, and so ultimately get rid of the infection. And with the slightly reduced seroprevalence as it comes through, slightly reduced force of infection, it might be even easier to protect. So we shouldn't dismiss vaccines that have 50% efficacy, but we should do much more modeling to ask how good are they and how could they be deployed. Obviously, these are in developed countries with a relatively low seroprevalence. I wouldn't want to use them in very high 99% seroprevalent communities where there's a massive amount of virus at a very early age. But for our types of communities to get going, they could be the first generation vaccines to be used. We shouldn't dismiss them too early.
Hear, hear.
Excellent. All right, thank you very much, everyone. So let's move on to another question. So this one was specifically for asthma in the chat. So someone was hoping you could comment on the use of valganciclovir rather than use of valacyclovir during pregnancy after the first trimester when there's a lower risk of teratogenicity.
So yes, the valganciclovir is contraindicated, so it's not recommended to use in pregnancy because of the potential teratogenicity, means sort of affecting fetal development, and also potential carcinogenicity, which means causing cancers. I mean, the question about whether actually, if you pass the first trimester, so the first third of the pregnancy, do you think it's okay to give it? And the answer is no, because we don't really have data on safety of giving this drug in the pregnancy at all. And therefore, at the moment, there's no recommendation, and I'm not really aware of any clinician in the UK or even sort of other countries that would recommend valganciclovir in pregnancy.
Okay, excellent. Thank you very much. And okay, so another one for pregnancy then. So how about prophylactic treatment during pregnancy? So for high risk women who have a toddler at home, for example, and they know they're seronegative, if you've established all that information, how about prophylaxis with valacyclovir?
That's a very interesting question. I guess if you, I can understand the rationale behind it because it's relatively safe, but a safe drug is not an excuse to give it without an indication, because it's still an intervention, it's still a drug, it's still a fetus that's been exposed to a drug during development where we have not really followed up these babies for years. So at the moment, there is no evidence to say that this is beneficial, to the best of my knowledge, and I would not recommend just giving it to women who without an indication.
Excellent, thank you. And then, so here's another one then. So is the risk of transmission greater in women with prior congenital CMV? So think about this, obviously, as the question is asked, but also if we knew that that was due to a reactivation, is it then also riskier to have a second reactivation in another pregnancy?
The problem with secondary CMV that is really difficult. I personally find it difficult as well to counsel the patients, and in my experience, many of them will end up by having amniocentesis just to confirm or rule out fetal infection or congenital infection in that pregnancy. I think a lot of the literature is not really of high quality. So yes, there is a risk of reactivation, but I don't think we have any estimate or any sort of accurate estimate of the risk in future pregnancy, because diagnosing secondary CMV is very difficult. It's not that straightforward. And I said that's harmony, despite the fact I'm very pro testing. I mean, that's what my job is. I'm a fetal medicine specialist. Having had experience of the race fit, where we actually tested this woman early in pregnancy, and all those who had sort of controversial results or query secondary reactivation in the first trimester, I had to see them. You could see that actually dealing with women's anxiety and the fact that the uncertainty and often having to offer amniocentesis, it's something that if you're going to implement it, you need to take into account. You need to have a guidance about how to manage, how to counsel this woman, how to reassure them. So it's not that straightforward.
Okay, Soren.
Yeah, I think that the problem with this question is that we just don't know in non-primary infections what proportion are due to reactivation versus reinfection. It's clear that at least a large proportion of them are due to reinfection during pregnancy, and so that comes back to this counseling and education about risk reduction and avoiding exposures.
Okay, excellent stuff. Thank you very much. Right, so on to another question from a parent. So is it not important to repeat an MRI scan of a child born with congenital CMV when he is growing up, preschool ages, to see that the changes in his brain formation and to know what permanent damages have occurred, to possibly try to pinpoint what difficulty the child will have? And also, at what age should we comfortably be able to stop fearing there won't be any hearing loss? Would anyone like to take that?
I mean, I can just say it depends. You know, the reason to do brain imaging at birth is really to decide about antiviral treatment and to give some sense of prognosis. Beyond that, you know, there's not a lot to do in terms of using brain imaging data later. Sometimes families benefit from that, particularly I know in Canada and the US, if they can document a brain abnormality, sometimes they get services. They get certain services paid for. But in terms of, you know, what we would do clinically for a kid, or the support that we think a kid would need, or being able to predict hearing loss later, there's probably very little value to subsequent MRIs.
Paul Griffiths.
Yes, I agree with that. I always say to parents in this situation that you never stop worrying about your children. Mine are in their 30s now, and we still have concerns for them. You'll never be able to forget about them. With congenital CMV, the longer it goes on without you developing any problems, the lower the likelihood that you're going to have a serious problem. And so no news is good news. And that's probably the way to look at it.
Okay, excellent. Thank you very much. Let's just move on. So another question is, how about a lateral flow test for saliva for congenital CMV? We're all used to lateral flow tests now. And so could parents have these at home? Anyone like to jump in?
For the mother, you mean, or for the mother?
Yeah.
For the pregnant woman.
Mm-hmm.
Well, I'm not aware that we have a lateral flow test for CMV, but I mean, I think it's an interesting idea. And I think if there is, commercial company that would produce a reliable test, not like the lateral flow test for the COVID, which I don't think is reliable, I think will be actually potentially useful in the first trimester.
Great idea.
Because remember when I was saying is actually if in order to benefit from the evidence of the preventive or the role of the valganciclovir to reduce the risk of transplacental transmission, you really need to test this woman, identify the one who have a primary CMV infection either in the preconception period or in the first trimester. But if you say do the test at 6 weeks and it's negative, how do you know that the woman did not get the infection just like a few days before, or gets the infection until the end of the first trimester? And if you have this lateral flow, which is sensitive or is a good test, why not? If they can do it every week, for example. I mean, it sounds like for me, it's like a interesting idea.
I could chime in on that. Yeah, so there were a lot of lateral flow saliva tests in development for newborns, proposed for newborn screening. I don't think there are any that are actually out on the market. So I do agree that shedding in your saliva is certainly indicative of a reactivation, if not a primary infection. So then it would put them into a high risk category that as you've mentioned and Soren's mentioned, you can do a lot of testing on a smaller number. So yeah, I think if there were a test, there would be some value in that.
I think it's potentially interesting. I think the devil would be in the details. To me, using it early in pregnancy could hold some advantages, but you'd probably want to limit it to women you already knew were seronegative. And then, in terms of the potential use in newborns, I could see some utility there as well. Although I feel like we'd just be letting public health programs off the hook for providing high quality screening programs, which I think are needed, and I think it would probably result in an insufficient solution for parents to have to do this themselves.
Okay, so Paul, then Asma.
Yeah, just slightly different. Sorry, not following on directly from that. It's a slightly different technical question. I wasn't sure the great work from CMV Action showed about a lot of delayed diagnosis, which is a real problem. I wasn't sure how those diagnoses were made. Are people going back to the births, dried blood spots, or do children continue to shed? I can see Dr. Cleal nodding, so the answer's there. Just tell me.
Yes, they go back to dried blood spots if it's after 21 days, because you can't confirm it's not congenital after 21 days. So lots of the people I've supported, it's been going back to the dried blood spot. And sometimes it's inconclusive, and sometimes there's a delay. One person I supported, they only were able to test them once a week and things. So it can add in quite a lot of delay into the process.
How easy is it to get to those dried blood spots, Sarah? Is it?
I think in my experience, it was quite easy once they're discovered, but I think there can be issues. I'm sure Asma's probably better at this than me, but I think there can be issues sometimes. But I think actually the location is quite easy to get to. It's more that it isn't always definitive, as I understand it.
Okay, thank you very much.
And Asma?
I entirely agree with Sarah's comment, but the reason I had my hands up is that because I do remember that I think one of the questions was, I can't remember from who, and I was looking through them, someone who was almost offering or asking whether there is, sort of any need for some epidemiological studies to support maybe in, vaccine development or more intervention trials for CMV, and something like that, which is lateral flow, whether in the saliva or perhaps maybe in the urine, because certainly pregnant women, when they have reactivation or if they have a primary infection, they're likely to excrete CMV. So I think if there's an opportunity for perhaps epidemiological study, I think that would be something that's relatively easy to set up and also would help in raising awareness among pregnant women about CMV.
Okay, excellent. Right, so coming on to a few last closing questions. Firstly, one for Sharon and Sarah. So what's the most requested help that parents seek from CMV Action? And do they seek help mainly during pregnancy or after birth?
Shall I answer that, Sharon? I don't honestly know. I would say it's completely mixed and very hard to predict. Some weeks we'll have a lot of pregnant women getting in touch, and sometimes it will be a lot of babies who've been diagnosed. Sometimes we get contacted by people who are considering IVF and want to know about their CMV status. So it's a huge, broad range. It's impossible to predict, I'd say. Obviously, we just urge anyone that wants support to contact us.
Okay, excellent. Asma.
And maybe just to comment on the IVF, because I think my observation is that so many women who are undergoing IVF will have CMV testing, but not all. And I don't know whether there is any standard policy or protocol for actually testing these women who are undergoing IVF.
I think they generally had testing, and they're asking whether a donor should be positive or negative, depending on what their results are. And we normally pass it on to our one of our medical experts, to be honest, because we don't feel it's something we can really answer. We have got a little bit of information on our website, but we do get, and we also get queries from people who've been in contact with someone, a child with CMV, for example, and are very concerned. So we get a lot of a whole broad range, I'd say.
Asma?
I mean, I think just to, maybe to bring it to the discussion, one of the question about this, what happens in CMV during COVID, which I think is really interesting because certainly when we had the initial wave, where we usually would see sort of referrals with CMV, we saw no CMV at all. And I don't know whether just people were not testing and we're missing the cases, or because women are staying at home and therefore maybe there is potential less transmission, but actually most of the transmission occurs from their own children anyway at home. Or was it just people were maybe alert about hygiene measures and therefore maybe there is less chance of maternal CMV infection? I don't know whether other people have similar observation, or have you seen any data on what happened to CMV during the COVID pandemic?
Soren?
Yeah, so there is a little bit of data, and actually Mark posted it in the chat. It does seem like, at least in some places, rates of congenital CMV might be lower because of COVID. We don't screen in Quebec for congenital CMV, but it doesn't seem like the rate of referrals to our congenital CMV clinic have decreased during the pandemic. We're still seeing a lot of cases, but I think it's quite interesting if it turns out to be true that the kids staying home from daycare and or moms and kids being more attentive to hygiene, if that indeed does result in a demonstrable reduction in congenital CMV, that just bolsters all of the justification for education and counseling of pregnant women.
So I'm going to move to Mark Schleiss, who's just promoted to panelist to help us answer this question, and then on to Sheila after that.
Yeah, thanks so much. I don't have anything to add much to what Soren just said, except to make a plug for a talk and a poster at this meeting this week. We had the advantage in collaboration with Sheila and the Minnesota Department of Health to have an ongoing study, so we were able to quite carefully look at what happened pre and post COVID, and in fact the prevalence has decreased quite substantially. So I'll show some of that data in the poster and in my talk. And like many infectious diseases during COVID, there's been a big impact. And I think, this will teach us a little bit about risk factors for maternal and congenital CMV. And we should learn from that and implement those in the future and talk about that. I think like many things with COVID, it will be interesting to see as we emerge from the pandemic, if we will go back to previous trends or if we can learn from some of these observations and change our behaviors in a way that decrease the rates of infection of other viruses, including CMV. So anyway, that's all I had to say, but thank you for the opportunity to comment.
Thanks very much for joining, Mark. Sheila, did you have anything on that one?
I just was going to say what Mark Schleiss just said, so no need. Thank you.
Okay, excellent stuff. And Paul?
I was just going to thank Mark for that, because there are many opinions on this area, but I think his will be the first data. I look forward to seeing it. Can I ask him a really difficult question? Does he have a feel for whether COVID and the restrictions that have been brought in have reduced women's exposure to virus generally, or has it been their children who've been less able to go out and socialize with other kids and so bring the virus back into the home? Can you disentangle those two things?
Perhaps, and I think the epidemiology and patterns of transmission of CMV may differ from one population to another. In our Minnesota surveillance data, almost all congenital CMV infections are in second pregnancies in women who have older children in group daycare. And so there's quite an impact of parity. And I think that may not be true in every population, but I think that decreased use of daycare and restrictions from school, homeschooling, working from home, I think those might be really important variables, as well as broader hygienic precautions. I mean, I'm not sure that the behaviors within a nuclear family in a household changed as much as all of our behaviors when we went to the grocery store or out into public. So I think the key point is getting it in the household in the first place. And if children aren't in group daycare centers where they're getting rapid and frequent exposure to CMV, that maybe that's the critical point. And I hope we can untangle that further, but those are just kind of some preliminary impressions we have.
Okay, excellent. Thank you very much. Any more comments on this before we move on? All right, so last three questions. So firstly, there's quite a specific question about testing for renal impairment. So that's kidney impairment. So how often do you check for kidney impairment during treatment with valacyclovir in pregnancy? And how do you dose the 8 grams per day? Do you give it all as one dose or do you split it up? Asma?
Okay, that's a very good question because, as I mentioned, the valacyclovir, the studies that reported that's potentially useful in CMV use this large dose of 8 grams per day, and the tablet's usually 500 milligrams, so you need to give 16 tablets, and we usually give 2 grams every 6 hours, so that's about 4 tablets 4 times a day. And I know the French tried to maybe have a 4 grams twice a day instead of 2 grams 4 times a day. And I think they did report that there was, I think, detrimental effect of giving this very large dose, but maybe with like twice daily rather than 4 times daily. The question about whether actually with someone with renal impairment, whether we should reduce the dose or not, I don't know. We don't have really evidence. In this case, I probably will need to maybe get in touch with the company and just understand, or maybe ask about the pharmacodynamics.
So whether we should test for renal impairment in someone on valacyclovir. Did they test during the trial? Or?
Well, I mean, in my practice, I do. So before I start, I would have a baseline, including liver functions and renal function test and full blood count, and I tend to repeat them during the pregnancy. But in the trial, I'm not sure actually that they have tested. I suspect they would have tested initially, but I don't know whether they have repeated it. I don't know whether Paul Griffiths might know.
So again, it's difficult to remember the paper, but the question I think is well made. It's the renal function, but it's not just of the mother, but also of the fetus, because the drug is renally excreted in the fetus, and the drug can crystallize out and so give you a post-renal failure. And so the thing to watch for is oligohydramnios during the pregnancy. And I recollect there was one case, was there, Asma, in the study? And I'm sure you monitor for that, don't you?
Yes, so this one will have an ultrasound scan every 4 weeks, and because we keep looking for signs of sort of fetal abnormalities, we often repeat the MRI. But there are 2 different groups, isn't it? So there is one group that you would give the valacyclovir for prevention of transplacental transmission. So at this stage, you don't know whether this fetus is infected or not, and waiting until you do the amniocentesis to confirm that hopefully the baby is not infected, and at that point you will stop the valacyclovir, and the baby will have testing at birth. So for that, it's not an issue because actually the baby is not infected. I mean, the other group that they actually do have the infection, and whether you can argue that whether we should continue the valacyclovir or not, even in absence of abnormalities, because you're trying to minimize any potential ongoing damage by the virus. And then the group that's in the French study, which is a mild to moderate group, where you're actually giving and then monitoring closely. And of course, if you see that there's already abnormalities, particularly significant abnormalities, in this case, in the UK at least, we do discuss the option of interrupting the pregnancy if the parents wish to.
Okay, excellent. Thank you very much. So in the interest of time, we'll just move on. So just to last two questions. So just to come back to the very first case we mentioned right at the beginning of this Q&A, if you remember the parents of the 3.5-week-old where the mum developed CMV in the 3rd trimester, baby's asymptomatic and has passed hearing and vision tests. So they say baby can still have hearing problems up to the age of 6. Can she develop any other health problems such as seizures, developmental issues and vision loss? And if so, what are the common ages for these problems to occur? Soren.
So the short answer is if the baby is asymptomatic, indeed, as we described after an evaluation, the only risk to worry about is hearing loss. So there's pretty good evidence that that other than hearing loss, the risk of any of these other complications is extremely low.
Okay, excellent stuff. Thank you very much. So just on to a wrap-up question, really. So what should we be looking for going forward? So on my list, I've put that we probably need a bigger trial of valacyclovir during pregnancy. So we've got more centres. We definitely need more education for women. And we can talk briefly about how we could achieve that. And we probably need more centres to start screening newborns. Can anyone comment on any of them or say anything else that we need going forward? Obviously, a vaccine to be efficacious is one of the most important too. Soren. Well, then Sheila.
Yeah, thanks. I absolutely agree. You know, prevention during pregnancy, screening newborns, to me, is the right thing to do. I think until we have a vaccine, we know that we can be helping an enormous number of kids with this. And then again, I think that we have some hard work to do in terms of understanding how best to implement a vaccine and what the regulatory requirements are for approving a vaccine, so that we're not excluding vaccines that could be reducing disease right now.
Great. And Sheila, then Asma.
Yes, from a diagnostic standpoint, better blood spot tests. I know that blood spots fall short with sensitivity. Soren mentioned about 80%, 75% sensitivity, which is people are going forward with them because you can. It would take an awful lot more money and time to start with saliva or urine. So it'd be great if the blood spot test could get better. And then the other test that we could use is avidity. Standardize the avidity testing. That's all.
Perfect. Asma.
And maybe just to comment on follow up from Soren's point, and maybe just to make a plea for the vaccine trials, is whether they would consider giving a booster dose during pregnancy to try to reduce the chance of secondary CMV, which is again sort of contributes to the majority of congenital CMV infection cases.
Paul Griffiths.
Yeah, so I agree with Soren. The two big initiatives will be to have an effective vaccine and to be screening neonates. And those two things are linked, because if we have a vaccine which at the moment is directed against preventing primary infection during pregnancy, although the vaccine is being given to some seropositives, that's really to demonstrate that it is safe to do so rather than looking for efficacy at this stage. You have to remember that the majority of congenital CMV cases don't come from primary infection in the mother. And you can link those two things together, because by introducing a vaccine program, you could then see that cases of congenital CMV coming down if we had national screening, and you could say what number will we expect and how many are we bringing it down and how efficacious is it, and that would put the pressure on to make a vaccine that can boost the immunity of seropositive women effectively so that they don't reactivate or become reinfected during pregnancy.
Excellent, thank you very much. Sheila, did you have another comment? Or, No, okay, all right, brilliant. Fine, and then just one last bit of a question from Mark, who's been helping to host this. So is there any single piece of advice that public health bodies could give in order to reduce the risk of congenital CMV, to prevent congenital CMV? Any single bit of advice? Asma, and then Sarah.
So yes, I mean, it's raising awareness, it's education. And as I mentioned earlier, I think educating pregnant women, I think is a bit late. You almost need to educate everyone, all women, because they need to know that even before they get pregnant, because in case they get the infection in the periconceptional period. So, and just to maybe give you sort of an idea about the efforts that's happening in the UK. So now NHS England, or certainly now they do. In the past they didn't. So in the advice that the pregnant woman gets at early stage in pregnancy, CMV was not included, and that has recently changed. So now the CMV, the education and awareness is included. So that's a positive step in the right way. But in the right direction. But actually, for me, I think it's a bit late. You almost need to educate all women about the risk of CMV.
Okay, excellent stuff. And Sarah, last comment from you. Oh, you're on mute, Sarah. Sorry,
I was just going to add in that just awareness amongst the general public and also professionals, because obviously everyone here is very CMV aware, but that isn't. Lots of people we support there, the people who deal with them, GPs, midwives, medical professionals, don't actually have an awareness about CMV. It's not a rare virus. And obviously awareness is going to be particularly important, particularly if we're thinking about a vaccine in the future. We need people to be aware that this is something we should be trying to prevent as well. So awareness, I'd say.
Okay, excellent stuff. A good note to end on. All right, well, I'd like to finish by thanking very, very much all of our panelists. It's been a really fascinating session, and thank you so much for your giving up your time. We'll be putting this recording there'll be a Zoom link coming out quite soon on the website, and then we'll aim to move it over onto the recording onto YouTube, so people can carry on watching it in perpetuity. And thank you to all of the attendees for joining us and all of your very interesting questions. Thank you very much. Goodbye.
Thanks, Mike. Bye.
Thank you.
Thank you very much.
Great.
Thank you. Bye-bye.
Thank you.